Every third trimester ultrasound functions as a real-time, dynamic readout of a highly pressurized biomechanical engine. In this system, every structural anomaly and fluid imbalance acts as a specific mechanical tracer. By tracking these deviations, a clinician can isolate exact fetal organ failures or underlying maternal diseases before delivery. This cross-section highlights the 3 distinct zones that dictate fetal survival. The evaluation must independently verify the amniotic fluid space, the umbilical cord, and the placental-uterine interface. The first zone is a dynamic, closed hydraulic loop. Fluid is constantly generated, circulated, and cleared in a precise mathematical balance. The second zone is the umbilical cord, acting as the sole vascular tether bridging the fetal circulatory system to the maternal supply. The third zone is the placenta itself, functioning simultaneously as the structural anchor and the primary metabolic exchange interface. Mastering the physical forces acting across these 3 interfaces builds an intuitive and predictive model capable of diagnosing obstetric emergencies. The origin of amniotic fluid changes as pregnancy progresses. Early on, the fluid in the amnion and chorionic spaces is simply a filtrate from the membranes. But after 16 weeks, the fluid is predominantly manufactured by the fetus itself as urine. This continuous input-output system is maintained by fetal kidneys and cleared by swallowing. An AFI below 5 defines Oligohydramnios, pointing to failing kidneys or placental insufficiency. An AFI over 20 defines Polyhydramnios. This broken output isolates a defect in swallowing or the lower GI tract. There is one critical maternal exception to this GI rule. High maternal blood sugars, specifically from gestational diabetes, will independently drive excess fluid production, resulting in polyhydramnios without a fetal structural defect. While evaluating these volumes, you may notice fine particulate matter suspended in the fluid. This is a normal baseline finding, especially in the 3rd trimester. Measuring the fluid pocket is an active functional test. You are directly assaying the performance of the fetal renal and gastrointestinal systems in real time. The umbilical cord requires specific vascular geometry to safely transport high blood volumes. A normal cord contains exactly 3 vessels, 2 arteries, and 1 central vein. This cross-section compares the standard anatomy to a frequent variant. On the left, the normal 3 vessels form a classic Mickey Mouse appearance. On the right, we see a 2-vessel cord, characterized by the absence of 1 artery, typically the left. A single umbilical artery occurs in about 1% of pregnancies, often as a benign finding, but it mandates immediate screening for maternal diabetes, or twin gestation, and chromosomal anomalies. Beyond the vessel count, the stability of the tether depends entirely on where it anchors to the placenta. A central insertion provides maximum protection, while a marginal insertion anchors near the physical edge. This maps the 3 insertion pathways. A velamentous insertion forces delicate vessels to travel unprotected through the membranes. This mechanical vulnerability significantly increases the risk of intrauterine growth restriction. If these unprotected vessels cross the internal cervical os, catastrophic vasa previa occurs. Vasa previa occurs through 2 distinct mechanisms. Type 1 is driven by the velamentous cord insertion we just mapped. Type 2 occurs when fetal vessels stretch across the os to connect a bilobed placenta, or an accessory lobe, to the main body. Inspect the cord for persistent cysts. These structures, remnants of the embryonic allantoic and omphallomesenteric ducts, typically regress as midline development completes. Their persistence into the 3rd trimester indicates a failure in embryonic regression, an anatomical marker often associated with trisomy 13 and 18. Evaluating the umbilical cord maps the physical limitations of this vascular tether. It lets clinicians predict where mechanical stress will cause vessel failure. The placenta matures predictably over the course of a pregnancy. A normal sonographic appearance reveals a granular texture with a smooth chorion cover. As it ages, it naturally accumulates randomly distributed calcifications and focal hypoechoic areas. But the true diagnostic value lies beneath the placenta. The retroplacental complex is a critical network of veins that serves as the anchoring foundation to the uterine wall. When the placenta implants abnormally low in the uterus, it can physically obstruct the birth canal. This is placenta previa, a condition carrying severe risk of maternal hemorrhage. Accurately diagnosing previa requires a strict procedural protocol. The maternal bladder must be empty. If the bladder is full, it will compress the lower uterine segment and create a false positive. This sonographic map plots the precise position of the placenta against the internal cervical os. A marginal previa rests within 2 centimeters of the os, but does not cover it. A complete or central previa structurally seals the exit, physically blocking the opening. Because the lower uterine segment thins out as pregnancy progresses, these low-lying attachments eventually tear. This creates the classic clinical presentation of placenta previa, painless vaginal bleeding in the 3rd trimester. This precise mapping of the placental edge provides a definitive answer to one logistical question: whether a safe vaginal delivery is physically possible. A properly placed placenta can still fail if its attachment is compromised. Placental abruption is the premature separation of the placenta from the uterine wall, a severe emergency. This comparative cross-section isolates the critical distinction. On the left, severe retroplacental abruption presents as a dark hematoma that violently tears through the retroplacental complex. On the right, a benign contraction gently bows the complex, leaving venous structures intact. The opposite problem occurs when the placenta anchors too deeply. The placenta accreta spectrum defines a condition where placental tissue abnormally invades the uterine muscle, driven by prior scarring. Here we see 3 stages of abnormal invasion, sonographically appearing moth-eaten. Severity is graded by depth. Accreta attaches to the muscle, increta invades it, and percreta punches completely through the uterine serosa. Percreta carries a massive risk of life-threatening hemorrhage, often requiring an emergency hysterectomy. When evaluating the placental structure, you may also encounter focal masses near the cord insertion. It is critical to distinguish a benign chorioangioma from a dangerous internal hematoma. The definitive test relies on vascularity. A chorioangioma is a benign fetal tumor. Doppler ultrasound will reveal pulsatile flow synchronized to the fetal heart rate. A hematoma, however, is entirely avascular. By rigorously interrogating the retroplacental interface with these parameters, a sonographer can instantly separate a harmless structural variant from an imminent catastrophic hemorrhage. This tripartite model synthesizes the sonographic data. Evaluation relies on validating the hydraulic fluid system, vascular cord, and structural anchor. Extremes in fluid volume require targeted fetal renal or gastrointestinal workups. Variations in cord insertion or abnormal placental location predict perinatal hemorrhage. Identifying benign distractors, such as an avascular hematoma or a displaced venous complex, isolates the invasive pathologies that demand immediate intervention. By treating the gravid uterus as an interconnected mechanical engine governed by hydraulic inputs, vascular transport, and structural anchoring, medical professionals strip away diagnostic trivia. What remains is a precise, predictable logic of maternal and fetal survival.